Today we're going to talk a little bit about oxandrolone, and I'm going to review some of the very scant literature out there on oxandrolone as it relates to blood clotting disorders. So this subject came up because I was actually talking with a colleague of mine, and he asked me if I prescribed it routinely for my patients, and I said no, it's really not part of my practice, which is really more longevity based. And I'll talk a little bit more about why I don't routinely prescribe oxandrolone and some of the actual indications for it. I have prescribed oxandrolone in the past on a number of occasions, but they were actually for burn patients, and this is many, many years ago. So oxandrolone goes way back. There's got a long history of use in various catabolic disorders, and I'll talk with you guys a little bit about that. But we were talking about whether or not the addition of oxandrolone to for example, to a TRT protocol, would that increase the risk of blood clotting, like deep venous thrombosis, DVT, or pulmonary embolism, possibly stroke? And those of you guys that listen to my channel should know that obviously the evidence that testosterone therapy in and of itself, testosterone monotherapy, being related to increased clotting risk is extremely poor. In fact, we've pretty much put the nail in the coffin on that at this point. But what about when you add in, an oral anabolic steroid that gets processed by the liver? And we know that other anabolic steroids, orally taken anabolic steroids, can skew some of the coagulation parameters that are out there, and so theoretically could result in an increased risk of blood clotting. So I did a dive into the literature to see if I could find anything on oxandrolone. And not surprisingly, there's not a heck of a lot out there. But I'm just going to present one study to you guys, just so that you have this information. I'm not going to try to talk you guys out of using oxandrolone. I think it's what you put into your body is your own personal decision. And I've become a lot more libertarian as I've gotten older. And if this is something that you want to include, then I think as long as you're a well-informed consumer, I think you should be able to do that. The problem is, of course, accessing good information. There are a lot of these clinics now that have have heavily marketed oxandrolone as an adjunct to TRT, and in my opinion, there's not a really strong, legitimate use case for oxandrolone in that regard. But that doesn't stop them from marketing the hell out of it. In preparation for this talk, I mean, I saw dozens and dozens of clinics online as I was, doing some searches. All of them are offering nandrolone. All of them are offering oxandrolone, in addition to obviously GLP-1s and testosterone and a bunch of other adjuncts. A lot of this is just a money grab, to be honest with you. But we'll talk about that. I don't want to divert too much from the topic of today's talk. So, as I mentioned, there are a lot of legitimate uses for oxandrolone. So it's been FDA approved, I think, gosh, since the mid '60s, I think, for a variety of wasting and cachectic diseases. So things that happen after major trauma, major surgery, people that are confined to their beds for long periods of time after bouts of sepsis and whatnot. It's particularly useful, or has been useful in the past, before antiretroviral therapy really came to the forefront in HIV wasting. It probably saved the lives of a lot of HIV patients back in the 90s, and it still gets used for that. It's highly effective for that. It believe it or not, is used not uncommonly in pediatric populations. So that should kind of give you an idea of its relative safety. I mean, if they're using it in children, the safety profile is certainly better than other oral anabolic steroids, without question. And I'll touch on that just a little bit. But um, where most of the use of oxandrolone, at least that I've seen in my emergency medicine career, was in burn patients. And a severely burned patient is that is a critically ill and injured person, someone who has large percentage of their body surface area affected by burns, goes through this very severe hypermetabolic state in the acute phase of that burn recovery, and they lose muscle tissue at it's an accelerated rate that you wouldn't believe. So over the years, they've looked at a lot of interventions. How can we help people maintain what they call positive nitrogen balance and not lose all this skeletal muscle tissue because they just waste away. And of course, that makes them more prone to infections and other long-term complications, not to mention it makes the skin grafts not heal as well, and just the long road to recovery that some of these people have, it just makes it even longer if they lose 40% of their muscle tissue, which is not uncommon. So oxandrolone has been used for a long time in many burn centers. I've seen that personally, and it can be quite effective for that. It really can help, especially when it's combined with other modalities like high protein intake, et cetera. There are studies with growth hormone as well being used with oxandrolone. I can't say that I've ever seen that, but oxandrolone it tends to be favored in the burn community and in this critically ill and injured recovery world because it has honestly a fairly good safety profile. It has a high anabolic to androgenic ratio, so, yeah, there's less of the androgenic effects that you see with a drug like testosterone, for example, or some of the other agents that are out there. But like I said, it gets used for a lot of different things. One of them is congenital short stature in kids. There's something called Turner syndrome, which is where a person is missing one of their sex chromosomes. So all of us, if you're male, you have an X chromosome and a Y chromosome. Sorry, YouTube, but that's what that's a male. And if you're a female, you have two X chromosomes. Well, patients with Turner syndrome, they're female, but they're an XO, so they lack that second. They only have 45 chromosomes instead of 46, and so they have a number of congenital abnormalities. As you can see in the photo here, they have kind of a characteristic syndromic look with the webbed neck, short stature. They have these things called their ovaries are really underdeveloped. They have like what they call streak ovaries, and then sometimes they have congenital heart issues, like something called coarctation of the aorta, where the aorta becomes very stenotic at one point in its course. They can have aortic valve issues, so like bicuspid aortic valves, and develop aortic stenosis and stuff like that. But there is a use case for oxandrolone to help them become a little bit taller, and it's reasonably effective for that. So anyway, so it gets used for a lot of other stuff, but obviously it made its way into the bodybuilding world probably not long after it came onto the market in the medical world in the 60s. It certainly was used by a lot of the golden era bodybuilders, and it still gets used today because it's the anabolic to androgenic ratio is so favorable. It obviously appeals to female athletes because there's less virilization, and again, its safety profile, I think, is what has made it popular among some of these TRT and longevity clinics. Even though, in my opinion, and based on the literature, there's no longevity benefits whatsoever to taking oxandrolone that I can identify. Feel free to argue with me, or feel free to point out some literature that maybe I haven't seen. But I don't think that there's a longevity case for the use of oxandrolone. The clinics that push this stuff, they talk about injury recovery, which is not untrue. If you are injured, obviously anabolic steroids will help you recover more quickly. If you've had major surgery or some sort of physical trauma, of course, there's data to support that. But they also talk about gaining strength and muscle mass, they some of them just flat out say performance enhancement, which really I think is they're treading on thin ice there with the FDA, because that kind of marketing is definitely a no-no, and sooner or later it may catch up with them. But um, the way I look at any hormone, if you have a deficiency in it, obviously it should be replaced back up to normal levels or to healthy levels, whatever that might be. And in some cases, believe it or not, that might actually be super physiologic, and that's based on the data that's out there. But regardless, nobody has an oxandrolone deficiency. your body doesn't produce oxandrolone, and you don't suddenly develop an oxandrolone deficiency like you develop a thyroid hormone deficiency or testosterone deficiency or an estradiol deficiency. This is not a naturally occurring hormone. So as far as longevity goes, it's not. It's taking oxandrolone is not going to add a single day to your life chronic if you take it chronically. At the best, it would be neutral. It would not affect your lifespan, and I think in the worst case scenario, potentially could shorten your life if you took it for long enough. And so it has to be taken into context. And I guess if you're going to use oxandrolone, I think the best use case for it is going to be for a brief period of time to help you recover from an injury, or to achieve some other tangible parameter, and then you come off of it at that point. So again, feel free to disagree with me in the comments section if you have experience with oxandrolone. If you feel like it's really improved your health in whatever way, please let me know about it. But those are just my thoughts of it. I'm not trying to talk you out of taking oxandrolone or trying it. I just want to give you guys the best information that I can to make that decision. So, as I mentioned, as far as oral agents go, I mean, it's relatively safe, especially, if you think about at the standard doses that people take, 2.5 milligrams, 5 milligrams, the maximum is up to around 20 milligrams. And there's studies at 20 milligrams. Even there, some of the potential issues with the liver injury, there's something called pileosis hepatis, which is these large, like blood-filled cystic structures that develop in the liver. It used to be seen a lot in people that abused, more potent and more harsh anabolic steroids like Anadrol and Dianabol, and they can rupture and hemorrhage, and it can be a big deal. Liver cancers and things like that. All of those are exceedingly rare with oxandrolone, especially if it's used at standard doses, and only ever showed up in case reports in people who used high doses for prolonged periods of time. So, like, we're talking about a year or more. So, to be perfectly frank, it's relatively safe if it's used judiciously and under physician supervision. If you have your liver function tests monitored, that sort of thing, it will probably not do your lipid panel any favors. I didn't include it in the talk here, but there were plenty of studies showing unfavorable lipid changes. So if you are prone, or if you have cardiovascular disease, I mean, you need to take that into account. Um, but generally, the most common things are these minor and somewhat transient elevations in liver function tests, AST, ALT, for example, that are asymptomatic and that normalize after discontinuation of the drug. So, and again, this is why they give this drug at low doses to children sometimes to treat some of the conditions that I talked about earlier. So, okay, what about blood clotting? So I looked and I looked and I looked, and I certainly could have overlooked something, but there are, to my knowledge, no good like randomized studies, even retrospective studies looking at like insurance databases. So the low quality evidence studies, looking at DVT, deep venous thrombosis, pulmonary embolism, or stroke in people who use oxandrolone for either short or long term or any length of time for that matter. However, I was able to find this one study here. This is from the American Journal of Hematology. It's from 2006. It's called The Effects of Oxandrolone and Anabolic Steroid on Hemostasis. So they did not look at rates of DVT or PE in these patients. In fact, there was only 14 subjects in the entire study. So you have to take this study with a grain of salt. But I still thought it was interesting enough to include it and do a little talk for you guys about it. So what they did here is they took 14 healthy men, aged 21 to 55, and so by healthy I mean they were not allowed to have high blood pressure, diabetes, they couldn't have liver disease of any kind. They couldn't have high cholesterol. And they said, quote, any other chronic disease. So presumably these were pretty healthy people. And they put them on, the maximum sort of standard dose of oxandrolone, which was a total of 20 milligrams. And they did it, they broke it up 10 milligrams twice a day. And they did it for 14 days. So it's just a short study, 14 subjects for 14 days, 20 milligrams total of oxandrolone, and they did baseline blood work looking at a number of different blood coagulation parameters, and then they tracked them over the 14 days. So they did, they do obviously drew blood on day one. They did it on day 3, 7, 9, and then on day 14. And then they did a washout period out to 42 days to see if things would normalize and go back to baseline. And spoiler alert, they all did. Okay, so what happened when these guys took oxandrolone? Um, so this is what they looked at, first of all. So they looked at plasminogen. They looked at something called PAI-1, which is plasminogen activator inhibitor 1. And I'll talk a little bit about these as we go along. And then they looked at a number of blood coagulation factors. So it's factor 2, 5, 7, 8, and factor 10. And then they looked at platelet aggregation, so how sticky their platelets were. And then they as I said, after the 14 days, they repeated these over time. They went out to 42 days when they checked them at day 21, 28, and then 42 because they wanted to see if they normalized. Okay, first of all, before we go into that real quick, so this is the coagulation cascade. It always gives me a little bit of heartburn when I look at this because we had to memorize this in medical school, and I've memorized this and forgotten it for tests. Probably at least half a dozen times in my career. It's not the kind of thing that, unless you're a hematologist, you really need to commit to memory. But I put it up here just to show how complicated it is to make a blood clot. There's a lot of factors here. And by the way, all of these are genetically mediated, so you can have problems with some of these factors, and that's where things like hemophilia come in. And so you can have bleeding disorders if just one of these factors is absent or hypoactive. So it takes a lot to make a blood clot. There are some of you guys out there, because I see you on the forums and I hear it in YouTube videos every now and then that are, that just grossly oversimplify this whole process here. And what I mean by that is, you know, I, they'll say things like, well, I donate blood so I don't get a blood clot. Well, nowhere in this cascade here do you see hematocrit, right? You don't see red blood cells being involved in the formation of a fibrin clot. So, many of you guys that donate blood thinking that you're not going to ever have a stroke or not have a blood clot of any kind, that's just simply untrue. I can't tell you how many people who are frankly anemic come and see me in the emergency department with huge pulmonary embolisms and deep venous thrombosis in their legs, their arms, other places in their body that have low hematocrits because they're chronically anemic. So it has nothing to do with their ability to form a fibrin clot. So this is a very complex process. It's easy for it to go wrong, either from an acquired condition, a medication, something like warfarin, which is a old school blood thinner, still gets used a lot, or a genetic problem like hemophilia. Okay, moving on to the study. We'll just race through this real quick because I realize it's a little dry. Okay, so these are a couple charts here. This is what happened with plasminogen. So you can see it nearly doubled by day 14. Levels nearly doubled. Okay, and then pretty much after they stopped the oxandrolone, things like pretty rapidly. It took a little while. It took 7 days to get close back to baseline. And then obviously by day 28 and certainly by day 42, things were normal. So plasminogen is a precursor to plasmin, which helps break down clots. So this is raising plasminogen would theoretically make you less likely to clot. Okay, so that's interesting. So the next chart here is the PAI-1, the plasminogen activator inhibitor 1. Okay, and you can see that this one, it didn't increase, it actually decreased. Okay, so increased levels of plasminogen activator inhibitor 1 could lead to clotting. So if it's increased, in this case, it decreased. So now we have two of the factors at least that that are involved in clot formation, two in favor of anticoagulation, I guess you could say, when it comes to oxandrolone. So what about the rest of these? Okay, so factor 2 and factor 5, which I just lump up here together, both of those significantly increased. Okay, so which would suggest if you have more of these factors that perhaps you would be more likely to form a clot. So we have two changes so far that would potentially make you less likely to clot, and then we have two factors here that could potentially make you more likely to clot, theoretically. Okay, theoretically. Um, so factor two rose 100 up to 122%, and then factor five went up 179%. And again, those would be, I think you could say that safely that those are procoagulant. That would be a procoagulant shift. Okay. Factor eight didn't change at all, and then factor 10 minor increase. It went up to 107% from 96%. So that's a minor increase. It's probably not clinically significant in terms of actually leading to clots. And then as far as platelet stickiness or platelet aggregation, there was no effect from oxandrolone. So what do we have here? So in a nutshell, oxandrolone, it increases both pro-clotting factors and anti-clotting factors. So it's probably a wash. There seems to be a balance between a procoagulant tendency and an anticoagulant tendency, at least when it comes to the levels of these proteins in the blood. So huge caveats here. Huge caveats here. They did not look at, it was only 14 patients for 14 days. They did not look at if these guys developed a clot. Presumably, if they did in the 14 days, they would have mentioned it. So all we're looking at is biochemical changes on a lab test here. And as you guys know, that sometimes can look very different when you look in the real world. What we need is studies with a few hundred of these guys over many, many years, perhaps, and looking at what are the rates of thrombosis in people who take oxandrolone at various doses and for various durations of time. And we just, to my knowledge, do not have those studies. If you know of one, please let me know. I looked pretty thoroughly through PubMed earlier today, and I could not find one. If anyone tells you that oxandrolone causes blood clots, as far as I can tell, there's no data to support that statement. There's obviously can be other issues with oxandrolone, so you just need to be aware of that. I would proceed with caution if you, for example, if you have one of these hereditary thrombophilias out there, factor five Leiden, um, protein C, protein S, et cetera, lupus anticoagulant, antithrombin 3. There's a whole bunch of them. If you have one of these genetic predispositions, then again, I would be a little bit cautious. We just mainly just because this is uncharted territory. I should be cautious anyway if you have one or more of those conditions. If you've had a clot before if you had an unexplained clot, I should say, if you had a good reason to have a clot, like you had a femur fracture, then maybe this warning doesn't apply. If you take a blood thinner, specifically if you take warfarin, there's actually a number of case studies where oxandrolone really raised the INR and caused bleeding complications in patients. One of them was a single case study with like a very elderly person. I think they were in their 90s, and it shot their INR up, and they had bleeding complications. So if I was taking warfarin, I probably would not take oxandrolone. And if I did, there's a really good chance that I would probably need to bump my warfarin dose down because there's going to be some interactions there. Uh, definitely, like, obviously, I would hope that you're under the supervision of a physician if that scenario applies to you. I personally wouldn't risk it, and I would add that to some of the newer anticoagulants, the DOACs. So those are your Xareltos and your Eliquises and things like that. I'd be very cautious with using oxandrolone, even though if you put my feet to the fire, I can't tell you that there's any data that it is that puts you at increased risk of blood clots just because there is no data on it. But you know, and I've gotten more conservative as I've gotten older, so um, I would just be careful about it. So that's really all I had for you guys today. I mean, overall, I'm not gonna. I hate scaremongering, so I'm not gonna do that to you guys. I think the standard doses of oxandrolone, especially for brief periods of time, for a specific use case, a catabolic condition, recovery from an injury, etc. I think that it's relatively safe to do that, assuming you already have a healthy liver and don't have any of the caveats that I mentioned earlier, and that you're doing it under the supervision of a doctor. Um, Again, do I think this is a longevity aid? Absolutely not. I don't think that there's any long-term advantage to you being on oxandrolone. You will gain, you'll probably put on some muscle tissue, you might lose some fat, and for cosmetic and performance enhancing reasons, yeah, absolutely, because that's what anabolic steroids do. But they certainly don't add years to your life necessarily. So proceed with caution and just be smart about it. Let me know if you have experience with oxandrolone. Like I said, I've never taken it. I really don't have any interest in taking it. I feel pretty good all the time for the most part for a guy my age. And I've already put on I think as much muscle mass as I need to and I just want to hold on to it as I get into my 70s, 80s and 90s. I want to stay functional. I still want to be able to do jujitsu, etc. Um, so for me, I'm just not particularly interested in on oxandrolone. And again, my practice is really more about longevity and optimal health. And it's oxandrolone really doesn't fit into that, in my opinion, at least long term. So feel free to disagree with me, and I value you guys. You guys have great opinions and great insights, and many times you get me to think about things that I haven't thought about before. So I'm certainly open to you trying to change my mind. So go ahead and post in the comments if you have anything to add for that. Otherwise, I'll catch you guys next time. Bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.